Good morning. I'd like to thank the organizers for inviting me to speak with you today about some lessons that we've learned about vaccination against SARS-CoV-2, the virus that causes COVID-19. My name is Jeffrey Silversweig. I'm a professor of clinical medicine at Weill Cornell Medical College and the chief medical officer of the Rogosin Institute, both located in New York City. I'd like to thank my colleague, Dr. Alan Kleiger from Yale University, for his review of these slides. Dr. Kleiger and I together co-chaired the American Society of Nephrology's COVID-19 response team. His role was later assumed by Liz McNamara from Northwest Kidney Centers. She and I together continue to lead the Nephrologist Transforming Dialysis Safety's COVID-19 and Other Emerging Threats work group. I also chair the American Society of Nephrology's Emergency Partnership Initiative. With that introduction, there have been numerous barriers and facilitators of vaccination against SARS-CoV-2. First, to give you a scope of the problem in patients with kidney disease, COVID-19 caused disproportionate morbidity and mortality in patients with end-stage kidney disease. In fact, for the first time in the 50-year history of the Medicare ESRD program, as you can see from this slide taken from the 2023 USRDS annual data report, the population of patients with end-stage kidney disease in the Medicare ESRD program decreased. Importantly, outcomes were worse in historically underserved communities. As you can see in this figure, also taken from the 2023 USRDS report, the declines were more noticeable in those who self-identified as Black, Hispanic, Native American, Black, Hispanic, and Native American compared to Asians and whites. When vaccines became available in December of 2020, there were equity issues in terms of vaccine distribution. As everyone remembers, the supply of vaccines was limited and priority was given to those residing in group homes and those with underlying conditions that placed them at increased risk of poor outcomes. Notably, kidney patients were excluded from that priority group. Patients living in better resourced communities had better access to vaccines in the community. They had more resources to schedule appointments and more support. Vaccination sites tended to be closer to their homes, and for those who had to travel, they had more resources to travel for vaccination. In March of 2021, the American Society of Nephrology partnered with dialysis providers and the Centers for Disease Control and Prevention to arrange for a federal distribution of vaccines to dialysis providers through a network administrator model. We pooled data from almost 500,000 patients with end-stage kidney disease across the US. And notably, underserved communities had the biggest increase in vaccination. As you can see here, vaccines became available through this network administrator model in March of 2021, and the proportion of patients vaccinated increased sharply. Over time, the differences between minority groups and whites narrowed dramatically. You can see early on that Hispanics had a notable rise, and over time that Blacks had a notable rise as well. And again, these are self-identified groups. But there are ongoing challenges with vaccination. One of the biggest challenges that we have faced throughout the pandemic has been documentation of infection. As everyone knows, early in the pandemic, testing was not widely available. Some patients with milder upper respiratory symptoms were simply not tested for COVID-19 as a result. Some patients who tested positive outside of dialysis facilities didn't provide that information, so isolation was not available. Mandatory reporting of positive tests ended with the end of the public health emergency on May 11, 2023. Since testing will no longer be paid for by the federal government, it may not be as readily available to patients with suspected COVID-19. In terms of documentation of vaccination, most vaccines are now administered outside of dialysis facilities, and not all states have readily accessible vaccine registries. If patients don't always report vaccination to their providers, it's hard to know who's been vaccinated and who hasn't. In terms of best practices for vaccinating patients, patient comfort is critical. Patients need easy access to vaccines, and patients need to be able to rely on staff that they know to ensure their safety. Patients also need education regarding the safety and efficacies of vaccines. Printed materials and recorded videos are helpful, but hands-on encounters with physicians and nursing staff are better. Importantly, direct encounters with patients who've received vaccines are invaluable, but these educators need to be taught HIPAA regulations, and they need to be guided as to the right time and place for that education. Vaccine acceptance of influenza has been much greater than that of COVID-19. Dialysis facilities have consistently vaccinated more than 70% of their patients against influenza. As you can see from this slide, taken again from the USRDS annual data report published in 2023, the proportion of patients on dialysis vaccinated against influenza is more than 75%. However, in this paper taken from Dr. Priti Patel's group and her colleagues, published in JAMA in 2022, you can see that less than 65% of patients receiving dialysis in the US received at least one dose of COVID-19 vaccine. Clearly, a big difference there. Well, then the question becomes, why are the vaccination rates against influenza so much higher? Politics clearly plays into it. There's little controversy regarding the benefits of influenza vaccination. However, there are many COVID-19 anti-vaxxers. For some individuals, the risk-benefit ratio of vaccination is unclear. And some become concerned because of rumors that they've heard that mRNA technology used to produce the COVID-19 vaccines could interfere with their DNA or could introduce other foreign materials. COVID-19 vaccination rates in dialysis facilities have been seen to correlate with the rates in local communities. So in those communities where vaccination rates are lower, vaccination rates of patients receiving dialysis are also lower. There are also some misconceptions that play into lower rates of COVID-19 vaccination. Some people believe that they're immune after infection. And while there is immunity after infection, it wanes relatively quickly compared to the immunity provided by vaccines. Some also believe that because the newer strains are cause less severe illness and less mortality, that they don't need to be vaccinated. Importantly, vaccine trials excluded patients with advanced CKD and those receiving immunosuppressive medications, including patients with kidney transplants. That led to uncertainties regarding the vaccine's safety and efficacy in these populations, as well as uncertainty regarding vaccine dosing for patients with kidney disease. In addition, the vaccines received emergency use authorization from the FDA. Approvals outside of the typical FDA pathways led to concerns about the experimental nature of vaccines against COVID-19, as well as the vaccine technology. There was also concern that the rapid approvals that were granted to vaccines against SARS-CoV-2 might miss safety signals. In addition, underserved populations had concerns about experimentation, which were related, at least in part, to historical mistreatment, including the Tuskegee syphilis study. Addressing these misconceptions requires education. Respected government sources must provide consistent information, as has not always been the case throughout the pandemic. Providers must educate their patients, and patient groups must educate their members. The safety of vaccines against SARS-CoV-2 is now established in large numbers of patients from all walks of life with all sorts of underlying conditions. And again, the excess morbidity and mortality in kidney patients is clear. Again, we need to make it easy if we're going to successfully vaccinate patients. Vaccines need to be available where patients live, through chain pharmacies, dialysis facilities, CKD and transplant clinics, and community centers. Documentation of the eligibility for vaccination and documentation of that vaccination is critically important. Should kidney patients be considered immunosuppressed? We know that their responses to vaccines are less vigorous than the general population, and that's been clearly established with hepatitis B. In addition, cell-mediated immune responses are weaker among patients with advanced kidney disease than they are in the general population, and obviously patients with kidney transplants are immune suppressed in order to prevent rejection. In addition, it's important that registries be easily accessible to both patients and providers. The impact of the public health emergency is yet to be fully determined. Vaccines will no longer be available to dialysis facilities through the federal distribution that was established. However, dialysis providers may be able to purchase vaccines, but there's a question about reimbursement, partly because of how the vaccines are supplied. As we all know, the mRNA vaccines require cold storage, which is not available in all dialysis facilities. In addition, each vial contains 6 vaccine doses and must be used within hours of opening, which means there's likely to be some waste unless those vaccines can be repackaged to single doses. How will that waste be billed and handled? In addition, again, it remains unclear about recommendations for kidney patients. It's critically important that ACIP and CDC clarify recommendations for specific populations, including kidney patients. There's also a question about when kidney patients and providers should receive boosters. It's also important that we think of the variant-specific vaccines that are going to be available in September of 2023, not as boosters, but as specific vaccines, similar to the way that we approach influenza vaccines. Thank you for your time and attention.
Welcome to a webinar on routine vaccination recommendations for dialysis patients. The objectives of this presentation include common vaccination recommendations for dialysis patients, high risk of morbidity and mortality from preventable infectious diseases, and special considerations for dialysis patients. Infections are the second most common cause of hospitalization and mortality in end-stage kidney disease patients. They have higher annual mortality rates due to sepsis compared to the general population. One of the challenges is the immune response to most vaccines in dialysis patients that are less effective compared to the general population. Patients with advanced chronic kidney disease are at higher risk of infections. They are generally older with high number of comorbidities and compromised immune status. Nursing home residents, the patients who share transportation to and from dialysis, and in-center hemodialysis patients in close contact with other patients are at increased risk of infections. Their lower response to vaccines could be attributed to several white blood cell factors related to their quantity as well as functional quality as listed here. First, let's look at influenza vaccination. The graph illustrates a seasonal variation in monthly mortality among dialysis patients over a 5-year period, with the peaks coinciding with the winter months, with the exception of 2020 due to the COVID pandemic. The intensity and timing of influenza-like illness is associated with similar intensity and timing of deaths in end-stage kidney disease patients, with their peaks during colder months each year. Every 1% increase in quarterly influenza-like illness was associated with 1.5 to 2% increase in relative mortality. Seasonal variations were similar across different regions of varying climates. Seasonal variations were also observed in neutrophil to lymphocyte ratio and laboratory test results such as serum calcium, potassium, and platelet counts. When adjusted for these clinical variables, seasonal mortality differences were no longer seen. In a retrospective study involving nearly 37,000 dialysis patients from 900 centers across 3 networks during the 2005-2006 influenza season, mortality differences were noted based on vaccination rates, with the most favorable being for patients who received both influenza and pneumonia vaccines compared to neither. Influenza vaccine is recommended for everyone 6 months and older, with a few exceptions. The injectable formulations are either inactivated influenza vaccines or recombinant influenza vaccine, whereas the nasal spray is the live attenuated influenza vaccine. The injectable flu vaccine is generally recommended for patients with chronic kidney disease, whereas caution is warranted with live attenuated influenza vaccine. Augmented vaccines are approved for people 65 years and older. Flu vaccine is typically administered during September and October, though it is not too late beyond this period, and flu vaccine should be offered throughout the influenza season. For the last flu season, all flu vaccines were quadrivalent against 2 influenza A and 2 influenza B viruses. Most flu vaccines were manufactured using egg-based technology, though an egg-free, cell-based quadrivalent vaccine was also made available. It is now recommended that people with egg allergies can receive any licensed influenza vaccine that is otherwise appropriate. People who have a history of severe egg allergy should be vaccinated in a medical setting supervised by a healthcare provider who is able to recognize and manage severe allergic reactions. Flu seasons vary by the regions of the world. For instance, in the Northern Hemisphere, the flu season can begin as early as October and can last as late as April or May, whereas in the temperate climates of the Southern Hemisphere, influenza activity typically occurs during April through September. Travelers should consider these regional differences and get the flu vaccine at least 2 weeks before travel. Next, let's review the pneumonia vaccination. People with chronic kidney disease are at higher risk of pneumococcal disease and prone to its complications. In a USRDS study of nearly 300,000 dialysis patients, 1 in 5 developed pneumonia within 1 year of starting dialysis, and 42% of these individuals required hospitalization. Overall, the mortality rate from pneumonia is 14 to 16-fold higher in patients on dialysis than in the general population. In another study comparing patients with and without chronic kidney disease in Taiwan, chronic kidney disease was associated with increased risk of pneumonia with an overall hazard ratio of 2. The patients undergoing hemodialysis might be particularly susceptible to pulmonary infections for several reasons, such as transient hypoxemia during the dialysis procedure, exposure to other patients and staff at the dialysis facility and during shared rides to and from dialysis, weakened immune system, and multiple comorbidities. Until recently, 2 vaccines, the 23-valent pneumococcal polysaccharide vaccine, PPSV23, and the 13-valent pneumococcal conjugate vaccine, PCV13, were recommended for US adults. Pneumococcal polysaccharide vaccination was not highly protective against pneumococcal pneumonia without bacteremia. Introduction of pneumococcal conjugate vaccine that are efficacious against non-bacteremic pneumonia resulted in a major reduction of pneumococcal disease burden. Per the updated CDC pneumococcal vaccine guide, there are 2 newer vaccines licensed for use in adults 18 and older. 20-valent pneumococcal conjugate vaccine, also known as Prevnar 20, and 15-valent pneumococcal conjugate vaccine, Prevnar 15. The various pneumococcal vaccines target different serotypes, as shown here. No vaccine is 100% effective at preventing disease, but these pneumococcal vaccines are considered safe and effective to help protect against pneumococcal disease. For adults 18 and older with chronic kidney disease, pneumococcal vaccination recommendations are as follows. Individuals who have never gotten any pneumococcal vaccine may receive either PCV20 alone or PCV15 plus PPSV23 after 1 year. For others who receive PPSV23 only, either PCV20 or PCV15 may be administered at least 1 year after their most recent PPSV. If PCV13 and or PPSV23 were already administered, then PPSV23 may be given as previously recommended, or 1 dose of PCV20 may be used if PPSV23 is unavailable. Pneumococcal vaccines used either alone or combined with influenza vaccination in dialysis patients are effective and safe. A meta-analysis study revealed that compared with no vaccination, those who received both influenza and pneumococcal vaccines had nearly 30% lower all-cause mortality. Next, let's spend a few minutes to review hepatitis B vaccination. Viral hepatitis B prevalence is higher among hemodialysis patients. compared to the general population. Viral hepatitis transmission in hemodialysis was first reported in the 1960s and continues to date. Hepatitis B surface antigen has been detected on numerous hemodialysis facility surfaces, including hemodialysis machine control panels, doorknobs, clamps, and scissors. Dialysis staff can transfer virus to patients from contaminated surfaces by their hands or gloves, or through use of contaminated equipment and supplies. In addition to contaminated surfaces, cross-contamination to patients in dialysis facilities were also attributed to multi-dose medication vials and intravenous solutions that were not used exclusively for one patient. Injection medications that were prepared in spaces adjacent to areas where blood samples were handled, and dialysis staff who simultaneously cared for both HPV-infected and susceptible patients. Even in the absence of visible blood, HPV can remain infectious on environmental surfaces for 1 week or even longer. The risk that a non-immune individual with exposure to HPV-infected source will seroconvert is as high as 30%. Hepatitis B vaccine is especially relevant for dialysis population and highly effective in preventing hepatitis B infection when successfully vaccinated with adequate immune response. Higher doses of certain vaccines are indicated for adults on hemodialysis and other immunocompromised adults aged 20 and older. Commonly available hepatitis B vaccines and their dosing regimens are shown here. The newer vaccines, such as HEPLISAV-B, have simpler dosing recommendation. Hepatitis B vaccine is encouraged before the patient start hemodialysis. In a small Canadian study, the patients with the lowest level of kidney function and who were older and had diabetes were less likely to seroconvert. Patients on dialysis have shown a diminished response to the HPV vaccine over time. This is especially applicable to low responders, as shown on the left panel. Therefore, ongoing post-hepatitis vaccination response monitoring is crucial. HPV antibody titer should be assessed 1 to 2 months after the final dose. If the titer is less than 10, repeat dosing and subsequent antibody titer in 1 to 4 months should be considered. The need for booster doses should be assessed by annual testing for antibody to hepatitis B surface antigen and booster dose administered when the level is less than 10. If the titer remains below 10 after above steps, monthly hepatitis surface antigen monitoring is indicated. Finally, a few points on zoster vaccination. The recombinant zoster vaccine is currently recommended for adults aged 50 years and older, regardless of prior history of receiving an alternate zoster vaccine or having zoster infection. This zoster vaccine is also recommended for younger patients between the ages of 19 and 49 years who are or will be immunodeficient or immunosuppressed because of disease or therapy, including advanced chronic kidney disease and dialysis. Zoster vaccine should not be administered to a person with a history of severe allergic reaction, such as anaphylaxis, to any component of this vaccine, and anyone experiencing an acute episode of herpes zoster. The general guideline for any vaccine is to wait until the acute stage of the illness is over and symptoms abate. As a final reminder, it is important to recognize that vaccination recommendations are periodically revised. Please refer to the latest CDC and the Advisory Committee on Immunization Practices recommendations for timely guidance. Thank you.
Hello, everyone. My name is Tushar Chopra. I am the Associate Professor in Division of Nephrology at University of Virginia. With me is Dr. Monarch Shah, Second-Year Renal Fellow and Chief Nephrology Fellow at UVA. And today we present this webinar on vaccination recommendations in special populations amongst dialysis patients, a case-based approach. Let's go over the learning objectives for this talk. We will try to understand the immune responses can be varied in special populations like end-stage kidney disease, discuss the COVID vaccine recommendations for end-stage kidney disease transplant patients who are on long-term immunosuppression, emphasized the importance of shared responsibility of nephrologists and primary care provider in educating their patients about appropriate vaccinations, and learn about the vaccine recommendations in end-stage renal disease patients who have a weakened immune system either because of HIV or solid organ transplants, and finally try to understand the vaccine subtypes indicated in immunocompromised hosts. So with this, I'm going to start with the first case, and Dr. Shah is going to help me out with some answers. So this is a 58-year-old end-stage renal disease patient on dialysis secondary to HIV-associated nephropathy with a CD4 count of less than 200 and a percentage CD4 of less than 15, who just started highly active antiretroviral therapy and is new to in-center dialysis. He doesn't have a primary care doctor yet, and you see him on dialysis rounds, Dr. Shah, and he asks you, what vaccines would you recommend for him since he's new to dialysis?
Well, before I answer that question, let me take a moment to walk you through the CDC website's adult vaccine assessment tool, which is available online at cdc.gov. And all we need to do is enter the URL like shown here and hit enter, and then it takes you to the tool, which will then ask you some basic questions about your health. There are some questions that are shown over here which need to be answered. For instance, our patient in this case is a 58-year-old man and who is on dialysis. And just like you can see, he was born in the year 1965. He does not have any history of traveling outside the US. We are not sure if he has completed a polio vaccine series, and he does not live in a college dormitory or is not a first-year college student. So that's how you answer the questions, some basic questions. His medical history includes him having end-stage kidney disease, requiring dialysis, and HIV infection with a CD4 count of less than 200, which makes him highly immunocompromised. And apart from this, the list has some other clinical situations as well, like cancer, chronic liver or lung disease. And after all these questions are answered, you can click on the My Results button, which then takes you to the CDC recommendations page. So after answering all these questions and based on our answers put into the website recommends different vaccinations which are indicated in each of the scenarios. For example, this is a patient who is an adult and is 58 years old. So the COVID vaccine, flu vaccine, and the Tdap are recommended since he is an adult. And the shingles and Hep B vaccines would be recommended since he is 58 years of age. And considering the history of renal failure, hepatitis B, pneumococcal vaccines are recommended, and the fact that his CD4 count is less than 200 would by itself make hepatitis A and B, the meningococcal, pneumococcal, and the shingles vaccines indicated.
Well, thanks, Monarch, for that question answer and walking us through the CDC website. You know, there is a follow-up question I have for you. Is there a varied response to hepatitis B vaccination amongst dialysis patients?
Well, despite the answer to that question is yes, but despite having a lower response rate to the hepatitis B vaccination in end-stage kidney disease patients, there is a greater reduction in the risk of a hepatitis B infection in dialysis patients. And the patients on dialysis can receive either a conventional or the conjugated vaccine. And as a result, the risk of infection is actually lowered by 70% in vaccinated dialysis patients compared to the ones who are unvaccinated. Seroconversion into anti-HBs antibodies is about 50 to 60%. And hemodialysis patients usually receive a higher dose of the vaccination. And the inactivated or recombinant vaccine confers active immunity by formation of anti-hepatitis B antibodies.
All right. And let's say there is a follow-up on this question and his anti-HBs titers is still less than 10 million international units per ml after 1 month of the first vaccination series. What would be the next appropriate steps, Dr. Shah?
Well, after the vaccination is done, we should check for serologies within 1 to 2 months after the first series. And the patients who have titers that are less than 10, they should be revaccinated with an additional series. And once seroconversion is achieved, then annual anti-HBs titers should be obtained. And booster doses should be administered if the titers are less than 10 again. And despite an additional series, if there is no seroconversion, then we should check the surface antigen on a monthly basis. Another tip is that we can use an intradermal route for administration of these vaccines so as to obtain a higher response rate. And we must all remember that the efficacy of the adjuvanted vaccine in non-responders has not been established yet. Well, Dr. Chopra, I do have a question now. This patient had a CD4 count which is less than 200. And are there any special considerations in terms of vaccination for that reason?
Yes, most definitely. And, the data is kind of sparing, and we have to go to expert opinion and consensus guidelines. And I looked up the IDSA guidelines from infectious disease that brings about this table where I want you to focus on the right-hand side, which is the high level of immunosuppression, which is what our patient qualifies as because the CD4 count is still less than 200. And just to give you some context, R represents recommended, U is usual, and X is contraindicated. And let's walk through this table. The Haemophilus influenza B conjugate is very age-specific vaccination, and it would be usually recommended up until 5. In a highly immunocompromised patient, it would be recommended up until 18. It is not really studied in adults. Hepatitis, yes, there will be recommendation to give the Hep B vaccine in a dialysis patient, but IDSA recommends giving the 40 micrograms of conjugated Hep B vaccine to a highly immunocompromised host. Not much difference in diphtheria toxoid, Tdap. Those are usual recommendations. But the human papillomavirus, IDSA recommends a quadruple vaccine because of its effect against genital warts in patients who are between 11 to 26 years of age or at a high risk population. Influenza vaccine, the data is pretty strong in recommending that inactivated influenza vaccine would be indicated in a highly immunocompromised host, but the live vaccine would be contraindicated because they have not yet mounted the CD4 count. However, in someone who has a CD4 count who has a low level of immunosuppression, like they've been on highly antiretroviral therapy for over 16 weeks, and the RNA plasma concentration is less than 60,000 copies, you may consider giving the live influenza vaccine, which is located here. But that's a weak recommendation with very low quality evidence. In terms of other live vaccines like MMR or the quadruple varicella, MMR would not be indicated in a highly immunocompromised host. And just to finish up the list, pneumococcal vaccine, usually conjugated pneumococcal, PCV 15 or 20 is indicated in dialysis patients. But the polysaccharide pneumococcal could also be given in a highly immunocompromised host after 8 weeks of indicated dose of PCV 15. So those are the special recommendations that you would have in a dialysis patient.
Well, thank you for summarizing that for us. Let me take you to our second case for today. I have a 20-year-old first-year college student who identifies as LGBTQ with end-stage kidney disease from a failed kidney transplant and is seen on routine hemodialysis rounds. The patient continues to remain on low-dose prednisone and tacrolimus. He inquired about a LGBTQ-friendly primary care provider in the area and wondered what vaccinations would suit him.
Well, thanks for that interesting case. I will walk you through again the website, and these were the recommendations that would come. The end-stage kidney disease in age are pretty standard in terms of recommendations, but I wanted you to focus on the weakened immune system, and which is what qualifies you to get the shingles vaccine. Being LGBTQ, the hepatitis A vaccine would be recommended, and a first-year college student or a military recruit ought to get a meningococcal vaccine according to the CDC website. Now, Monarch, which vaccine subtype is safe in an immunocompromised patient?
Well, generally, all non-live vaccines can be administered safely to patients with an altered immunocompetence, and patients with most forms of altered immunocompetence should not receive live vaccines. But there's keep in mind that not all end-stage kidney disease patients have contraindications to receiving live vaccines.
Good to know.
And just so that we can complete a list of vaccinations that we should avoid in immunocompromised hosts, amongst that is the MMR vaccine, the varicella, yellow fever, rotavirus, typhoid vaccine, the oral typhoid vaccine, BCG, smallpox, and the live attenuated influenza vaccine. Now, taking the live attenuated influenza vaccine as a segue to the next question that I have for you, Dr. Chopra, is the flu vaccination recommended for patients with solid organ transplants?
Well, there are two parts to this question, Monarch. One is the dialysis population, and yes, the flu vaccine would be recommended in all end-stage kidney disease patients requiring dialysis annually, and the flu season is coming up. The Advisory Committee on Immunization Practices recommends a yearly inactivated or a recombinant quadrivalent influenza vaccine for individuals on maintenance dialysis. But keep in mind, the existing recommendations do not currently state the preference for the type of vaccine that should be administered in the dialysis patient. Now, to answer the question on solid organ transplant, yes, it is safe and effective to give influenza vaccine to individuals who have a solid organ transplant. And there is some data on this by Dr. Birdwell, who did a prospective cohort study in a single center that looked at kidney transplant patients, which is the solid line, and compared it to controls, which is the dotted line, where they checked antibody titers before and 1 month after vaccination by hemagglutinin inhibition assays for influenza type A, H1N1, A, H3N2, and influenza B. And the primary outcome that they were looking for was the percentage of patients that maintained seroconversion, defined by a hemagglutinin titer of more than 1:32. So just to give you perspective, for the influenza A H1N1, the kidney transplant patients maintained at 88.5% seroconversion, as opposed to 83% of the controls, so not difference at all. In influenza B, 81% of the kidney transplant patients maintained primary outcome, whereas 74% of controls. But when we looked at influenza A, H3N2, the kidney transplant group had only 66% maintenance of seroconversion, as opposed to 90% of the controls. However, this was not significant in an adjustment analysis. So the bottom line is influenza vaccine is very safe and effective in a solid organ transplant patient.
Thank you for that summary, Dr. Chopra. Another question that I have is what makes dialysis patients so special? And since we've recently gone through a COVID-19 pandemic, are there any learning points that we have?
Well, that is, we've learned a lot during the pandemic, Monarch, and I'm going to try and answer your questions in points. So what makes the dialysis population special is, one, dialysis or CKD was itself a risk factor to develop COVID-19. And in fact, studies have shown that being on dialysis had a 3.6 times adjusted hazard ratio of developing COVID. If you had a kidney transplant as a risk factor, you had 3.5 times the risk of developing COVID. And in terms of CKD, the risk was 2.5 times. Not to mention, they also had increased risk of mortality after a severe COVID infection. So for obvious reasons, this vulnerable cohort was prioritized early in the global vaccination efforts. In fact, we were giving out the COVID vaccine in our dialysis units, thanks to the government that subletted the vaccine to us. Also keep in mind, this population is special because they had a varied response to the kidney disease. Now, let me give you some more context. The patients who had dialysis dependency had lower rates of seroresponsiveness compared to the general population. the response that was checked was antibodies to M protein spike. And early on in the pandemic, we had post-vaccination seroconversion data after 2 doses of the mRNA vaccine. And the dialysis patient had approximately 80% seropositivity. Now, mind you, this is lower antibody titers compared to control patients who do not have kidney disease. And transplant patients had even lesser, like 20 to 50% seropositivity. Now, the antibody titers did improve after the 3rd and the 4th dose of the mRNA vaccine. And so what we've learned is that they did not mount a complete response, but at least they had a response. So despite the reduced seroconversion, there is still efficacy in the vaccine in these patients compared to the non-vaccinated patients. And that's important to know, because if you were to get COVID, the mortality was much higher. So the moral of the story is the monovalent mRNA vaccines are not recommended for primary series of vaccination. And in fact, CDC recommends 1 bivalent mRNA dose, followed by an additional optional bivalent mRNA dose after 60 days. And the additional doses thereafter are customized per needs of an individual risk.
Well, I think you did mention this a little bit during the previous slide, but can you tell us more about the response that the patients with a kidney transplant or dialysis have to COVID-19 vaccinations?
Yes, so there is a varied response, and there are several studies that I'm going to go over in the next few slides. This was one study which looked at immunogenicity, tolerability, and safety of COVID-19 vaccination among CKD, dialysis, and transplant in 4 university medical centers. And they looked at the seroconversion, neutralizing antibodies, and the T-cell response. And let's look at seroconversion. The dialysis patient had 99% seroconversion, which was still lesser than the healthy controls. But transplant patients only had 57% seroconversion, and their T-cell response was only 16%, and neutralizing antibodies only 79%. And the cohort tried to look at the specific characteristics in the kidney transplant patient, which was either they were all on mycophenolate mofetil, older age of the individual, they had shorter time since the transplant, which means they were highly immunosuppressed, and they had lower lymphocyte counts, which makes sense that if they are highly immunosuppressed, they won't mount a response. There is another study that I want to highlight, which talks about this varied response to the vaccine that looked at actual antibody titers. This is the Senkovac study, which assessed the humoral response in CKD patients, hemodialysis and transplant at 1 month, 3 months, 6 months, and 12 months. And this is a Spanish cohort. And you can see on the right-hand side that the CKD and the dialysis patients mounted a good antibody response to vaccination, especially after the 3rd and the 4th doses. And look at the transplant patients. Despite getting all the doses, some of them had poor seroconversion even after the 3rd and the 4th dose, which kind of tells you the bottom line is that reduced responses are not unexpected in a kidney transplant patient, which is the case with every other vaccine. But kidney transplant patients should continue to follow persistent isolation measures like wearing masks, hand hygiene, and get booster doses of COVID-19 vaccine in consultation with their nephrologist. And I also wanted to mention to you that there is a varied response in COVID vaccination amongst different immunosuppressants or regimens that have been used. So, for example, if someone has gotten rituximab, they would have a greatest impact on their seroconversion, even if the rituximab was given 6 months before. But let's say they are on calcineurin inhibitors, glucocorticoids, and mycophenolate mofetil, that correlated with a reduced humoral response, as opposed to azathioprine or mTOR inhibitors, which had a favorable response. So a strategy that was employed during the pandemic was to hold the MMF for 2 weeks. However, a long-term follow-up study revealed overall waning immunity at 3 months in follow-up. So I'll try to summarize the case 2 for you. Seroconversion rates in transplant and dialysis is low, but still vaccine is efficacious. So some protection is better than no protection. There is a varied response to COVID vaccine amongst patients with CKD, patients on dialysis, as well as transplant. And immunosuppression and vaccination should be tailored based on patient treatment regimen. So moving on to case 3, we have a 65-year-old man with end-stage kidney disease due to type 2 diabetes who has started in your dialysis unit. And on routine screening, you find the hepatitis B surface antigen is positive. He says that he's received the hepatitis B vaccine 1 week ago and wants to know why he has hepatitis B surface antigen positivity. What would you advise him, Dr. Shah?
So this patient likely has a false positive test result from the hepatitis B vaccine. We commonly screen patients every 6 months for hepatitis B, and in some cases, if they're not immune, we do screen them monthly. A false positive test usually should not be assumed as an infection and should not be treated without confirmatory testing. Now, to delve into this a little bit, I have a study that I looked up, which has a case series of 5 patients with CKD who developed a transient positive but a false positive hepatitis B antigen test, which was closely related to the vaccination. And hepatitis B surface antigen was positive in all of these 5 patients at a median of 4 days after vaccination, and a repeat surface antigen test was negative at a median of 13 days after the vaccination. And subsequently, results of the hepatitis B DNA PCR were negative for all of these patients, suggesting that it was a false positive test to begin with.
Mm-hmm.
And another study here, which has some evidence, which is based on a few case reports and a case series put together, shows an analysis to analyze the detection of the surface antigen in these patients. Amongst this evidence is a prospective study at the bottom of this table, which was conducted between January 1998 and June 2000 of de novo hepatitis B infection in over 2,400 dialysis patients who were screened monthly for a surface antigen using the standard enzyme immunoassay, and positive results were confirmed with a neutralization assay. 9 patients with a de novo surface antigen were identified and confirmed with the neutralization assay. And in 8 of the 9 patients with the de novo surface antigen, the surface antigen was temporarily related to the hepatitis B immunization. And at the bottom of this, at the top of this table, we have a study by Jansen et al., referenced at number 14, which revealed that one of the 6 patients had a detectable surface antigen for almost 20 days after the patient was immunized. So, a few learning points from this case in the next slide are that we have hepatitis B surface antigen should not be tested for at least 14 to 28 days after the vaccination to prevent any interpretation issues. And let's say if we have a patient on dialysis who ends up testing positive, vaccination history should be sought, and investigations including a repeat surface antigen and a viral load should be performed, and to rule out hepatitis B infection while the patient's dialysis machine is isolated. That brings us to our case 4, where I have a 65-year-old man who has an AKI because of multiple myeloma. He's on dialysis now and is about to get a stem cell transplant in a month. Would you have any special recommendations with regard to vaccination before he gets the stem cell transplant?
Yeah, stem cell transplant is adding a whole next level of complexity to a dialysis patient. And keep in mind that these would be the vaccinations recommended in a stem cell transplant individual, and the meningococcal and the human papilloma virus vaccine would be age or risk specific. And the antibody titers to vaccine preventable illnesses decline after someone has gotten a stem cell transplant. And the take-home point here is that primary re-immunization is required when the immune system is reconstituted, which would happen in 4 to 6 months. So like in the pneumococcal vaccine, you could give the 4th dose of the conjugated pneumococcal vaccine if graft versus host requiring immunosuppression, but for all others, the polysaccharide pneumococcal vaccine 23 would work. So to summarize this presentation, we have patients with CKD, dialysis dependency, and transplant with lower rates of seroresponsiveness compared to general population. Despite the lower rate of seroresponsiveness, there is vaccine efficacy in vaccinated patients compared to non-vaccinated patients with kidney disease. The live vaccines should be avoided in immunocompromised host, but not all end-stage kidney disease patients would have contraindications to live vaccine. Keep in mind the special scenarios, where they are getting a stem cell transplant or they are highly immunocompromised with a CD4 count of less than 200, just be mindful of those circumstances. And a nephrologist needs to have a shared responsibility with the primary care provider to ensure that all appropriate vaccinations are administered to their patients. Now, with this, we would like to end this webinar, and thank you everyone for listening to us, and thank you, Monarch, for chiming in on the cases. We learned a lot today.
Thank you.